Hi, it's Dr. Centeno, and thanks so much for taking the time to join me a little bit late. We're a half hour late. Hopefully you guys saw the time change from 1 p.m. Mountain to 1:30 p.m. Mountain. Got a great topic today, super interesting stuff, and really, hopefully something that's going to keep you safe. And that is, I had a case this last month where digital subtraction angiography made a big difference. And I know DSA is something you've probably heard about before, you've heard me talk about before. And I wanted to just show you how critical it is in upper neck injections and why making sure that it's so important that if you get the upper neck joints injected at 0-1 or 1-2, that the provider has DSA to do it. So we're going to talk about what is DSA, why it's important. I'm going to go into this specific case. I'm going to show you the images so you get a better sense of what it is I'm talking about. So without much further ado, we'll start that. Let me get that up and share my screen here. As usual, you can ask questions about this topic. You can ask questions about anything at all. So either one, let me get that DSA presentation up. Slideshow from beginning. Okay. Topic today is why you should never let anyone inject your upper neck without digital subtraction angiography. So what is DSA? Why is it so important? What the heck am I talking about here? You've probably heard me use that term DSA before. So let's get into it. Upper cervical injections are really unique because not only are they technically challenging, meaning difficult to do, but the anatomy is very complex and can be very deceiving. And the vertebral and other arteries snake through this area. And that's a big deal because an inadvertent injection in the wrong spot can really hurt the patient. So you've got this very complex anatomy here. And I know I've got some things written down there as to what's what, but just look at that for a second. That x-ray, that's what we see when we're doing this injection. And as you can see, it's confusing. And I have to say, when we have physicians training at Centeno-Schultz Clinic in Colorado, and we have a physician almost every week who's training there, who don't really do much in the upper cervical spine, like 99.9% of all interventional spine physicians, they look at this and they're confused. And so I'm going to do for you what I tell them. This is C2 here, just to orient you. And this is C1. So then you can see there the 1-2 joint and the 0-1. Now, when it comes to injecting a 1-2 joint, you go directly at the joint in the outer 2/3, but you can't do that with this joint. There's a joint right there. So this is the occipital condyle here. And so the 0-1 joint is sitting right here, but you can't go at it because it's a cup-shaped joint. And because it's a cup-shaped joint, you have to actually go where you can't see a joint line, which is way up in here, in order to get the back part of the joint. And that's what makes it very technically difficult. Plus, as you can see, this mishmash of shadows here really confuses even the most experienced interventional spine physicians. And then we got the vertebral artery. The vertebral artery supplies blood to the back of the brain. And it's obviously an extremely critical structure. So I want to just orient you here. This is C1, and this is C2, and this is C0, or the skull. Now, the joint I've got to inject is right there. That's the 0-1 joint. That's a 1-2 joint. So you can see a couple things, right? If we go too far lateral, then we hit the vertebral artery that's running right here. If you go too far inferior, then you hit the vertebral artery that's running right there. Now that vertebral artery goes up into the brain and it supplies blood to the back of the brain. Now, if a little contrast is injected inside that artery, no harm, no foul. But if you were to inject prolotherapy solution in there, like I will talk about, or even a clotty PRP or bone marrow concentrate, that could be a big problem for the patient. So this vertebral artery really defines why a lot of doctors don't have much experience with injecting this area. And what's really interesting is we've got a few, what I would call, in my personal opinion, crazies out there that are trying to do this on ultrasound. This is the ultrasound image that's being used for this injection. And I blogged on this before. There's all sorts of problems with the way this injection is being done. You would never go right at the joint like this if you were using ultrasound. You really can't see the vertebral artery in this image. Even if you could see it using something like Doppler, you wouldn't know if you were inside it. So the bottom line is that fluoroscopy is the way to go here, meaning X-ray guidance, because it allows you to do a test injection with contrast and make sure that's safe before you have to inject something else. And with ultrasound, you're just injecting what it is you're injecting. In addition, as I'm going to show you, by using contrast, we can use things like digital subtraction angiography to keep the patient safe. So what is this DSA? You've probably heard these initials before. It's digital subtraction angiography. And all it means is that you're subtracting out some of these confusing X-ray shadows and just showing where the stuff is going. Now, there's two looks on DSA. This is the original X-ray here. And then this is the look that we use, which sort of highlights the artery in this 3D type image, and you'll see that. And if there's high flow, you tend to see the artery in black in the type of DSA that we use. But it highlights the artery. It highlights what's moving and takes out the non-moving background. So that's what it is. And so it really lets you see if you're inadvertently in that vertebral artery. Now, what would happen if you inadvertently injected something in the vertebral artery while you're trying to do a 0-1 or 1-2 injection? If you injected Prolo there, it's probably a pretty good brain injury. And if there was anesthetic in the Prolo, then you'd probably have to artificially support the breathing of the patient for an hour to 2 hours. So you'd have to have a crash cart available, turn the patient over, put an oral airway in, then put an endotracheal airway in, bag the patient for 1 to 2 hours until they woke up, because what will happen is the breathing center will get knocked out. So the patient will not be able to breathe on their own. Now, what happens if you don't have that type of crash cart and that type of thing set up? There's just no way that the patient will survive long enough for 911 and the ambulance to get there. And that has happened. It actually happened here in Metro Denver about 15 years ago. So it's a thing. And if you were to inject PRP or bone marrow, the good news is that that's going to be less of an injury-causing thing, but you could still get a stroke if there's a large clot within the bone marrow or PRP. And that happens. Sometimes bone marrow will have small clots in it. Sometimes PRP will have platelet aggregates in it, which act as a small clot. So I want to show you this so you have some idea of what this looks like, right? You know, me describing it is one thing, but actually seeing what it is quite another. So this is a female patient in their 30s on the 0-1 facet injection. The flow of contrast didn't really look normal. Digital subtraction angiography was used. So let's see if I can do this here. I may have to. May have to stop this and restart it to be able to get this video to play. So let's do that here. Okay, so I'll show you the video and then I'll show you what's important. So this is the patient's injection. That's the facet joint. But then we see this stuff going here and we see something here. Now, that was really quick. And if you don't look at this all day, you might not know what happened. So I'm going to talk to you a second about why we even did digital subtraction on this injection. I did this injection, where the contrast was going didn't look right. Now, how do you know it doesn't look right? You do 1,000 of these and you say that one is not like the other 995 or 950 or whatever it is. There's something happening here because all the contrast I'm injecting into the joint isn't staying to the joint. At that point, I turn on digital subtraction angiography and see this. So what did I just see? Well, this is what I saw. That went by pretty quick, but this is the facet joint here. So the facet joint is being outlined. So again, that's the 0-1 facet joint, but I'm noticing that not 100% of the contrast is going into the joint. It's going someplace else. So that's an indication for me to turn on digital subtraction angiography, which I did, and then I injected more contrast. And we see here this dark rim here, which is the occipital artery, but we also see something else. We see the vertebral artery getting outlined, which basically means it has just some contrast going into it. And this is where I can't be. I can't inject into that artery and realize that that artery also lives right below me here. We're looking at a 2D picture. So bottom line is I see that there's something else going on. I abandoned this level. We were injecting other things in this patient, so it wasn't that big a deal because it's not safe to inject there. So that thing allows me, obviously, to prevent a very serious complication in that patient. So again, how would you know that there was something off here? You just have to do these all day, every day to know this doesn't look right. There's something else going on here. I need to get more information, turn on the digital subtraction angiography to see what's happening. So in summary, I would not let anyone, this should be let here, inject your upper neck blind with ultrasound or fluoroscopy without digital subtraction angiography. And there's just no substitute for these upper neck joints for lots and lots of experience because you have to know to turn on the DSA. You got to be able to interpret the DSA. As you can see, even interpreting the DSA is not trivial. You have to be able to look at that and say, aha, there's a faint outline of the vertebral artery here, and that's a no-go. So let me stop the sharing here, and I'll close this and take some questions. And we've got a lot of wind outside, so there may be some wind noise here, so sorry about that if you're hearing a bunch of wind noise. Questions. Bethany, Dr. Centeno, when you treat the vagus nerve through SCM, what exactly is it doing the vagus nerves and how is it helping it? So yeah, Bethany, we've been doing plate lysate hydrodissection around nerves for 2 decades now. And what happens when you inject PRP around the nerve or you inject plate lysate around the nerve? It's anti-inflammatory. In addition to that, PRP and the plate lysate, glasses are a little crooked here, has nerve growth factor, which can help repair the nerve. So that's the goal, is to try to put nerve growth factor, other growth factors like vascular endothelial growth factor or VEGF around the nerve. Bethany, is it okay to take muscle relaxers the day after PICL? Yes, that's not a problem. Fatchin, your knowledge, how many clinics are using DSA with these injections? Almost none. So let me break that down into two parts. The first part would be how many clinics are actually using contrast with fluoroscopy. And the answer is, of all of the clinics out there claiming to do these injections, probably 10% are using contrast with fluoroscopy. Now, a lot of that's just fraud, meaning there was never any sense that the provider has they were really injecting the 0-1 joint. They just call it that. But then if we get into interventional spine clinics that actually can do these injections and do use fluoroscopy with contrast, about 90% of those are not going to have digital subtraction angiography because it's a vascular package and it costs money. It's about a $20,000 upgrade on a $120,000 C-arm. So most clinics won't have checked that box because why do they need it, right? They don't inject this area. So there's no reason to spend that 20 grand if you don't have to. So the vast majority don't even have it. And then we get into what happened this week. We had a provider who was training at the clinic and had to ask one of our rad techs how to use DSA. He had it, but he had asked one of his rad techs how to use it, and she had no clue how to use it. She'd never used it before. So there's a substantial number of providers who have it, but they've never used it before, nor does the rad tech know how to use it. So it's very, very few who claim that they inject these joints that are using this technology to keep patients safe. Regenetics submitted advanced by Chris. Hello, I'm 47, have CP and a bad back. Cortisone had been amazing, but no longer effective. My last injection was March 6th. How long should I wait before trying PRP? Thanks for your help. Yeah, so Chris, I'd probably need to know a little bit more about where they were injecting cortisone, or corticosteroid. But the bottom line is the minimum waiting time is about 6 weeks. Maximum waiting time is about 12 weeks. So 6 to 12 weeks is a good washout period. Regenetics, been advanced by DB. How long after a fall in which I hurt my neck can one assume the vagus nerve issues I'm currently having could be resulted from that fall? I think that's too far a stretch to claim there's an association between the two. Regenetics, been advanced by Sherry Kopp. What percentage of doctors using upper neck procedures use this DSA thing? Yeah, so Sherry, I think I just answered that for FatGen. Very, very, very few are using it. Well, very, very few are actually injecting the joint. Even fewer have it. Even fewer than that understand how to turn it on, as I relayed for just the discussion just a minute ago. So very, very few. Amityville, when can you start eating after PICL? What the foods can or cannot eat? We feed patients as soon as they get into recovery, so there isn't an issue there. Amity, when you do PICL, do you also do posterior injections too, if that's required? Almost always. So we're almost always injecting the posterior and the anterior at the same time. Caitlin, when do I know if it would be beneficial to use a collar, hard or soft? How do I know if I'm getting fitted correctly if I get one off of Amazon? You know, a collar test is always a good thing, right? I think I've talked about that a number of times. If you think you may have craniocervical instability, buying a cheap collar off of Amazon is a good test. Now, you know, collar fit is always pretty specific for the patient. So what I mean by that is you may start with something like a Miami J collar off of Amazon, and then you may have to cut it down a little bit. You know, I've seen patients that have had to customize them take a little bit out in the chin area, take a little bit out back here so it doesn't press in the wrong spot. Make sure it's the right size, small, medium, large. Make sure all the adjustments on the Miami J collar are appropriate, etc. Now, having said that, that's a good test. And it may be a good thing to use when you're out and about, might get jostled going in a car, but you don't want to wear it all day or even for most of the day, only for short bouts, because it will weaken those critical muscles that you need to stabilize. Harry Winston, how can I get the instructions for the type of cervical MRI you've mentioned that can work to diagnose CCI when there is no DMX available? Yeah, so that's a functional MRI. So it's an upright MRI. The big things there are making sure you get maximum flexion and maximum extension. And that's on the MRI side. Now, if there is no DMX available, we also would recommend an open mouth lateral bending X-ray, right and left. So Carla has those instructions. If you just reach out to her, my assistant, she can get those to you. Thatchin, what is the stellate ganglion block? How is it performed and when is it needed? Stellate ganglion block is a block of the sympathetic ganglion in the neck. And when is it needed? They became very, very popular of late in military patients who had PTSD. So post-traumatic stress disorder, guys that were in military situations, they would do a stellate ganglion block, which basically gets rid of the fight or flight response because it would go through there. The signals would go through there. And there's been some thoughts they may be helpful in sympathetically maintained pain. So things like what used to be called reflex sympathetic dystrophy, which is now called complex regional pain syndrome. There's some thoughts that in a select group of headache patients, they may be helpful when that headache is being maintained through the sympathetic nervous system. Damien, good afternoon, Dr. Centeno. What are the best companies or businesses leading stem cell research, especially Regenexx? Stem cell research. Now, I probably have to break that into two categories. As far as clinics that are offering care that also do research, the answer is it's pretty much Regenexx or Regenexx, meaning there's no other company I know out there that's actively doing things like randomized controlled trials, that's actively publishing research 3 or 4 papers a year other than Regenexx. Now, if we go to the other category, which would be companies that are trying to produce FDA drugs, that would go through the 351 biologic drug pathway, there's a slew of those. They're all trying to do research through an FDA approval process. And I just did a blog on all of those companies that are out there and when their research starts and ends, probably 2 weeks ago, maybe 3 weeks ago. So you may want to look that up on the regenexx.com blog. Amity, what causes dizziness when you have CCI? Yeah, that's a really good question. So the upper cervical spine is responsible for coordinating inputs from your inner ear, your eyes, and the upper neck. And all 3 of those systems talk to each other and make sure they all agree. So it's kind of like a triple redundant system. Now, if one of those inputs is off, then you can get dizzy or nauseous or feel like you don't have good balance. And one of those systems is the upper neck. So the upper neck provides what's called proprioceptive or position sense information to make sure that it agrees with those other 2. So that's how that happens, is the information from the upper neck doesn't agree with the input from the inner ear and the eyes. And so you get those symptoms. Edwin, on the website, you mentioned that PRP might not be as effective for arthritis. I'm assuming this also applies to osteoarthritis, but a soft tissue injury, relatively young, 30s healthy patient. Regenexx ST stem cell procedure more likely to bring permanent healing. Yeah, Edwin, a lot of that has to do with the degree or severity of arthritis. So PRP is quite effective in mild and moderate arthritis, gets less effective in severe arthritis. In the severe arthritis conditions, we've seen that a bone marrow concentrate procedure like SD is more effective than PRP. Now, that also, there's sort of clinical indications that modify some of that. In the spine, you can get away with using PRP oftentimes, primarily because there's another instability component that PRP can help with quite a bit. So all of the pain is not usually generated by the joint. It's a mix of from the nerve and from instability in the muscles. So you're treating all of those things. So where PRP might underperform a bit in the joint, if it's severe arthritis, it's going to perform well in the other three areas. So patients do pretty well. Submit advance by Cheryl Sands. How many days do patients need to be in Colorado for the PICL procedure? Are there hotels and walking distance to the clinic, or do local hotels provide shuttles? Yeah, so that depends on if you're domestic coming from the US or international. If you're domestic and it's your first time, we want you to stay an extra 2 days beyond your procedure. And usually you come in the night before if you want to cut it close, or the day before if not. So that's for people who are from the US. Now, if you're from the US for a second procedure, not so much. Maybe stay the morning after. And if you know how you respond and you don't need a lot of recovery time, you can hop back on a plane. We just want that option to see you the next morning if we need to. And then if you're international, we recommend that you stay longer because the flights are much longer. So that would be staying an extra 3 or 4 days. You might get treated on a Tuesday and not leave till Saturday, that kind of thing. Same thing if you know how you're going to recover, you don't need a long recovery, you've never had an issue with snapping right back, then you can cut it closer, obviously, if you're coming in internationally. Liam, Hydroxin C, of all the subtypes you classify, do any respond to treatment better or more reliably than others? What's the most common subtype you see? Most common subtype we see is probably 2B. That's that side-to-side C1, C2. And that one responds about 70% of the time. Another common type would be C2-3 translation. So inflection, just saw one of those this morning. So that's a 3A, and that's another common type. And the response rates are probably 80, 85% with that one. So that's a good one to have. Now, that can go down if there's a lot of osteoarthritis in those C2-3 joints. If it's been going on a long time and there's a large amount of arthritis. Damien, what's your perspective on doctors that just inject inside the joint only for osteoarthritis? So Damien, if we're talking about knees here, which I think we are, but let me know, make sure I'm answering this correctly. The existing data shows that if you inject the bone and the joint, the patient will do better for longer. In addition to that, you also have to get rid of any instability within the joint. So if the ACL is loose, you've got to inject that. If the MCL is loose, you've got to inject that, etc. So I would say that if the doctor is just doing inside the joint, they're taking the easy way out. And obviously, if they're injecting the bone and the ligaments plus the joint, then they're actually thinking about this, following what the literature says. And it takes more time and expertise to do that as well. Kate, after a PICL procedure, do patients need to take time off due to recovery or increasing symptoms? Do you recommend taking time off to help with recovery? A lot of that depends on how you recover. And I know that's not a great answer, but it's a bell curve, as I always say. So listen, I did a number of PICL procedures this week. We had 2 of those 5 that had some difficulty recovering. One of those is probably not going to have much, and the other one will have more. He'll be a slow recovery. The other 5 will probably be recovering on the time horizon of 3 to 14 days, and that's most people. So I'd say 80% of our patients are in that 3 to 14 day time frame. So how much work should you take off would depend on the kind of work you have and how you've recovered from past procedures. That's a pretty good indicator. So for instance, if you're the kind of patient that gets a massage in the neck, or if you turn the wrong way suddenly, or if someone does a simple injection in your neck and you take 3 weeks to recover, you're going to need a lot more time off of work. Or if you've got a physically demanding job, you're going to need more time off of work. But if you're the kind of the patient that has done prior neck injections and they were no big deal, then I think a week off of work would be fine, as long as you don't work a physical job. Sean, can I get adjusted by an upper cervical chiropractor the day after I had PRP super shot, injected 3 to 7, also my AO joint? It wouldn't be an issue for us. So it shouldn't be a problem getting adjusted the day after an injection like that. I need to know a little more, but I just in general. Ankle. Yeah, Damian, we don't have a lot of data right now about injecting bones and ankles, although we think it helps. Definitely ligaments and joint are minimum 2 for ankles. Amity, what pain meds are usually prescribed after PICL, since we can't take NSAIDs or narcos are required to control pain? Yes, so we basically, people after PICL fall into 2 categories. Everyone gets a narcotic prescription that works for them. I would say that about half our patients either don't take it or take it for a day or 2. Then they're on Tylenol. The other half of the patients are taking their full script or even getting a second short script. So that's usually what happens there. Nina, good afternoon, Dr. Centeno. Will these C012 help with constant vertigo? Yeah, so if it's cervical vertigo coming from the upper neck, realize vertigo can also come from the inner ear and other things, brain problems, etc. But if it's coming from the neck, then it's usually coming from 01, 12, or 23. And so that these sorts of injections would help that. Hey, Ulysses, we're talking about upper cervical injections and the need for digital subtraction angiography. But again, all questions are on the table. So listen, guys, it looks like I'm running a little bit out of questions there. I think we're still in that spring break mode now. For various parts of the country are in spring break. So here we go. Bethany, if imaging post-PICL shows 20-25% improvement on overhang, but not much symptom improvement, would you think second PICL would give more symptom improvement as well as additional structural improvement? Would you think second would be similar to the first? Yeah, so in that situation, we usually ask the patient to move to a second injection. As far as how much improvement happens with a second procedure, I would say it's usually similar to the first in general. Now, not for everybody, right? We have patients where after the second one, they're done too. Lissy, is DSA really expensive to buy for pain management? Yeah, as I was saying before, Ulysses, it's about a $20,000 upgrade on a $120,000 C-arm. And hence, most practices don't buy it because they're not doing this, won't do many of these injections, or they're not going to do any vascular work. It's called a vascular package. So that's why most clinics don't have it that do this work, just because it is a $20,000 upgrade. Damien, on average, how long do you suggest physical therapy after a stem injection? It depends on what it is we're treating, but if we're talking about an unstable ankle, you would need to let the ankle come down first and get to full stability. So you probably wouldn't even start working on things other than range of motion until about month 2. And then we'd probably be looking at around 6 weeks of physical therapy to learn a home program. Sure, Stacy. Kate, when you treat the PI with the PICL procedure, have patients typically tried other types of injections or prefer to order a treatment, things to rule out before moving to PICL once CCI is identified? Yeah, so the type of injection is always determined by the type of CCI. So when it comes to a PICL procedure, that would be reserved for types of CCI like 2A and 2B, where we can only reach the ligaments from the front. However, if it was something like a 3A instability, then we would only do posterior injections and no PICL. And I would say about half of our patients that come through the door have had prior injections of some sort, maybe a little more, maybe 60%. Amity, is DMX done after every PICL? Not usually. Yeah, we don't normally pull the trigger on another DMX unless there's some question to answer. So if the patient comes back and says, yeah, I'm feeling 1/3 better, I'm good, here are the things I can do now, we're not getting a DMX in that situation. There's really no need to. If, on the other hand, the patient comes back and says, I'm not sure if I'm any better, maybe a little bit, then we're getting a DMX. Submitted advance by Henry Small. Where can we get the posterior injections in Europe first, or to see if those would help before the PICL? Well, the first thing you need before posterior injections is a diagnosis to see if posterior injections are going to help, right? As I was saying, some types of CCI won't respond to posterior injections at all, and some, all you need is posterior injections. So the first thing to get is a diagnosis as to the type. In Europe, we use algal cells in London to do those posterior injections, and they've got the ability to do those, but we first determine whether or not that's going to help, or whether we're just sort of wasting our time with posterior injections. Sean, I was diagnosed with cervical instability from 3 to 7, also diagnosed with chronic Lyme disease. Do you feel there's a connection? No, I don't feel there's a connection at all. We've got no credible data that shows that Lyme causes instability or the type of Lyme we're talking about. So I don't think there's a connection. Sure, happy to help. Lissy, I'm glad you're talking about this topic because of this naturopath called Drew Timmerman using a freaking ultrasound to inject someone C0, C1, which is dangerous. Yeah, that would be below the standard of care for sure. So if he were ever to get sued in a malpractice case, that wouldn't fly. There'd be MD spinal interventionalists that knew what they were doing lining up around the block to testify against that, simply because it's not a good practice. If you're inadvertently in the artery, there's no way to tell, or at least it's much, much more difficult to tell. So not an appropriate thing to do. You need fluoroscopy with digital subtraction. Listen, we've got lots of ultrasounds in the office. I'd love if I could do that injection competently under ultrasound and feel that it was safe for the patient. I wouldn't have to have a $140,000 C-arm. I could do it with a $35,000 ultrasound machine. I wouldn't have to have a room with lead-lined walls. I wouldn't have to have a $100,000 a year rad tech to run the machine. So it would be fantastic. I would make lots more money if I didn't need digital subtraction angiography with fluoroscopy to do it right. But you do. It's a couple $100,000 more of cost to me to do it that way. Again, I'd love to use a $35,000 ultrasound, but it's not going to make me feel safe about protecting the patient. Caitlin, do you have any opinions on GHK, CU peptides, or other copper supplements for supporting collagen after injection into recommendation supplements post-injection? We don't have any data that GHK-Cu or BPC-157 does anything after these injections. I know they're pretty popular. We have an ongoing research project where we're testing those against PRP. The existing data, for example, for BPC 157 shows it's less effective than a PRP shot in stimulating tenocytes, and that was actually with a research grade applied directly to cells. That wasn't with the stuff you take orally or you might inject. God knows what's in those things that that patients buy. They're not regulated by the FDA to even be what it is they say they are. So I don't really recommend any of that stuff. If you want to do it, I don't think it's a bad thing. No harm, no foul, but I don't think it's going to help. And then any supplements post-injection, we do recommend turmeric as well as fish oil and glucosamine chondroitin for our patients. Okay, guys, so I'm running out of questions here. So I'll start getting towards that wrap up, and then if new questions come in, I'll answer those. So where we are, we talked today about digital subtraction angiography and how critical it was in keeping patients safe and doing 0, 1, and 1, 2 injections. And I showed you an example today of what that looks like and the kind of experience it takes to be able to tell when to inject and when not to inject. Joey, hi, Centeno, watching from the Philippines, 4 a.m. Good man, up early. I was up today at 3:30, so I'm right there with you. Jennifer, hi, Dr. Centeno. Hi, Jennifer. Fatchin. Is there a connection between what is called hyoid bone syndrome or renal nutcracker syndrome and cervical instability? There certainly could be changes to the hyoid bone biomechanics as a result of CCI, but whether or not there's a relationship to what one person would call a hyoid bone syndrome and another one might call tightness in the anterior stabilizers, I don't know. Sean, if you're injecting the vertebral artery, when would you realize? Well, regrettably, if it's prolotherapy solution that you're injecting or any type of anesthetic, you would realize it when the patient can't breathe and their pulse oximetry goes to 0 and you need to intubate them or they're dead. That's when you would notice it. Now, if we're just talking about a clot, so clotted PRP or clotted bone marrow, then you wouldn't notice it till probably recovery, where the patient would have symptoms of a posterior circulation stroke. So that's when you would notice those things. But you'd notice either one of them pretty quickly. It wouldn't be something that would take a couple weeks, etc. It would be something that you'd either notice on the table or when they were in recovery. So that's how that would go. Okay, guys, any last minute questions for me? I will be here this Monday. We just had a couple more. Let's see what we got. Sally, could you clarify the requirement for a travel partner when traveling to Colorado for PICL? Is this compulsory? Can any other nursing arrangements be made if someone doesn't have a travel partner? Yes, Sally. So we do have a nursing service that can substitute for a partner, and we want that nursing service there all night. And that we're really trying to keep the patient as safe as possible, right? If you have an advocate there and there's some sort of problem where you need to see the doctor, you need to call the doctor, you need to get your phone and it's across the room, you need to get up in the middle of the night and use the bathroom and it's dark and you're a little dizzy, that's when having someone there to help is a big deal. So you can hire a nurse. That nurse would need to stay most of the night until you're stable and then would leave. So I would talk to Carla about hiring a nurse because that's definitely doable. We've had a number of patients do that when they didn't have a travel partner. It's been advanced by Harold Stein. What should we do if we needed hospital treatment after a PRP neck injection with just ultrasound? Who should we contact? Not quite sure what the question is. Meaning, and I think this has been advanced because maybe this person is not watching. So the question would be, Did you have a complication after another clinic injected PRP with ultrasound in your neck? And you're looking for someone to contact to see if there's a complication. Or obviously you should contact the doctor right away if you're having any sorts of issues. So the doctor can see if it's something that they need to take care of. So I'm not quite sure what you mean there. I'll put my email address down here so you can reach out to me if you're not watching live. Sorry for the wind noise, guys. We live close to canyons, so sometimes, once in a while, the wind will rip through here at 90 miles an hour. And it's one of those days. Okay, so this is my email address that goes to my desk. So if either one, reach out to me. Happy to try to assist you. Okay, guys, I want you to have a great weekend. And I will be here on Monday, hopefully without the wind noise. And I'll have a new topic on Monday. And thanks for watching. Thank you.